They are broadly divided into three groups: Mycobacterium tuberculosis complex, non-tuberculous mycobacteria, and Mycobacterium leprae. So this all starts from a common ancestor, which is given in green, and after that there is so much variations that in today's time, even for the vaccine development, each country is having its own strain. So history, tuberculosis has been present throughout the history. We can trace it from the ancient till the modern time. In ancient time, the earliest archaeological evidence of tuberculosis comes from ancient Egypt, where our mummies dating from approximately 2400 before Christ shows pots spine. And the descriptions of the typical sign and symptoms of tuberculosis have been given in their ancient writings. So this is a picture taken from that, and as you can see, this is this area and this. That is pots spine. So in Greek and the Roman time, the disease was known as the name like phthisis or consumption. Consumption is the term which was used in Old Testament of the Bible to describe tuberculosis, and Hippocrates mentioned tuberculosis in many of his writings. Around 162 AD, it was the Greek physician Galen who prescribed a treatment for this disease consisting of fresh milk, open air, sea breezes, and the dry mountainous place. And this will be the standard treatment for next 1700 of years. So till we got any anti-tubercular drug, this was the only treatment available. In the medieval time, one form of the tuberculosis we do now know about during medieval times was an infection which was known as scrofula. It's a skin disease. Scrofula is the name given to the tuberculosis of the lymph node. So early monarchs who believed they ruled through divine power claimed the power to heal scrofula by touch. So King Edward I of the England is said to have touched 533 afflicted subjects in a single month in 1277. So you are curing tuberculosis by a touch. So Shakespeare also described this ritual to cure scrofula in his play Macbeth. Come in. And in the modern time, before the advent of this treatment era, this was known as the disease romanticized. The gaunt, fragile, vulnerable look of the consumption became fashionable, and it was considered glamorous to look sickly. This was especially true among those in literature and the arts. The true nature of the disease came into the existence when the Benjamin Martin in early 1700s suggested that the tuberculosis might be caused by the wonderfully minute living creatures. In 1865, it was Jean Antonio Villemin in his experiment on the rabbits demonstrated that tuberculosis could be transmitted. Robert Koch in 1881 presented a proof that the Bacillus tuberculosis was the cause of disease tuberculosis. These steps are known as Cox Postulates, and he also helped in the development of the tuberculin vaccine. What do you know by Cox Postulates? You know or not? If you know, you can stay in the class. If you don't know, then you can leave the class. I'll give you attendance, don't worry. But I will not give you the marks in your next exam. Tell me your roll numbers and leave. If you cannot sit in the class silently, you can leave. What was the important topic of discussion? Come, both of you sit there. तीसरे वाले को भी बुला लो, उसको अकेले लगे. So morphology of the bacteria, they are slender, straight or slightly curved rods. They are 1 to 4 micrometer in length and 0.3 to 0.6 micrometer in breadth. They are non-motile. They do not form spores or capsule. They stain poorly by ordinary methods like gram stain, but are stained well by the Ziehl-Neelsen method. They are pleomorphic, so they can be present like rod-like, thread-like, branching, granular, coccoid forms can be seen. And non-acid fast granular forms which readily stain violet by Gram's method and known as much granule and the acid fast Slanger's fragment of Mycobacterium tuberculosis are also seen. Chemical composition: 40% of the dry weight of the Mycobacterium may consist of lipid. One such class of lipid, which is known as the mycosides, is unique to acid-fast organisms alone. It is involved in some manner with the pathogenicity of Mycobacteria. So mycolic acid is a large alpha-branched beta hydroxy fatty acid. It varies slightly in size from one species of Mycobacterium to another species. These acids occur free or bound to carbohydrate either as glycolipids. In that case, they will be known as mycosites. Free mycolic acids provides the characteristic of acid fastness. Then there is cod factor. It is a mycosite that contains two molecules of mycolic acid esterified to the disaccharide trehalose. They are found in virulent mycobacteria, and its presence is responsible for a phenomenon in which the individual bacteria grow parallel to each other, forming large serpentine cords. So this fact means they all are growing parallel to each other and forming a large group. That is known as cord. Then there are sulfatides, a group of glycolipids which are multi-acylated trehalose 2-sulfates. They have been shown to inhibit phagosome-lysosome fusion and seem to enhance survival of phagocytosed mycobacteria. Then there is VEX-D, which is another complicated mycoside in which 15 to 20 molecules of mycolic acid are esterified to a large polysaccharide composed of arabinose, galactose, mannose, glucosamine and galactosamine, all of which seem to be linked to the peptidoglycan of the cell wall. It works as an immunomodulator. And there is LAM, that is lipoarabinomannan. It is a lipopolysaccharide. LAM appears to be an inducer of tumor necrosis factor alpha synthesized by the monocytes and macrophages. Epidemiology of tuberculosis. It is one of the leading causes of death due to the infectious disease in the world. Around 2 billion people are infected with Mycobacterium tuberculosis. Each year about 9 million people develop TB disease, and out of that 2 million people die. Who are the people at high risk for tuberculosis infection? The close contact of an index patient, low income groups and homeless persons, individuals who live and or work in special settings, healthcare workers who serve high risk groups, infants, children and adolescents, and people who inject drugs. So close contacts are people who spend time with someone who has infectious tuberculosis disease. It may include family members, co-workers or friends. On average, 20 to 30% of the close contacts become infected with tuberculosis. Low income group. It is linked to the higher risk of exposure. Possible reasons include factors associated with low income like inadequate living conditions, crowding, malnutrition, and the poor access to health care. Special settings include congregate and the residential settings like nursing homes, correctional facilities, healthcare facilities, homeless shelters, and the drug treatment center where there are more people and the less space. Risk of exposure to tuberculosis is higher than in other settings, and the risk is higher if facility is crowded. Then correctional facilities. Higher risk in correctional facilities may be due to inmates who already have TB infection, increasing number of inmates which are infected with HIV, and the overcrowded facilities promoting the spread of tuberculosis. Then one category is people who inject drugs. So people who inject drugs are more likely to be exposed to tuberculosis, become infected and develop disease due to the certain risk factors like being in correctional facilities or drug treatment centers, having poor access to health care, having a higher risk of HIV infection, and having a weak immune system due to the injecting drugs. Healthcare workers might be exposed to tuberculosis at work. The risk depends on the number of persons with tuberculosis in that particular hospital, job duties of the healthcare worker, and infection control procedure. Children and adolescents are at high risk if they are exposed to any of the adult who belongs to the high risk group. If a child has TB infection or disease, it suggests that TB was transmitted recently. Person who transmitted tuberculosis to child may still be infectious, and others may have been exposed. So if you are looking for a child, then search in the family also. People living with HIV. So HIV is the strongest known risk factor for developing tuberculosis disease, not just infection. So TB is the leading cause of death in people who are suffering with HIV and AIDS. The risk of developing tuberculosis disease is 7 to 10% each year for people who are infected with both TB and HIV. Individuals with certain medical conditions are also prone for the tuberculosis infection, like prolonged therapy with corticosteroids and any other immunosuppressive therapy, silicosis, diabetes, severe kidney disease, certain types of cancer, and the certain intestinal conditions. Individuals who are infected within the past 2 years are more likely to develop TB disease. So you must understand one thing, having TB infection is a different thing and manifesting the disease is a different thing. So all of us might be infected with tuberculosis at some point of time, but it's not necessary that either of us is demonstrating or the manifesting the disease. So if they are within the first 2 years, if someone gets infected, the chances of developing into disease are more. So this risk is approximately 5%, and the risk over entire lifetime is only 10%. Higher risk of developing TB disease once infected due to in these people, in this particular group, the greater possibility of later on acquiring any HIV infection, and these injecting drugs may weak immune system also. So how tuberculosis is transmitted? So TB spreads person to person through the air via droplet nuclei. So millions of tubercle bacilli resides in lungs, particularly in cavities. So Mycobacterium tuberculosis may be expelled when an infectious person either coughs, sneezes, speaks, or sings. So one cough can release approximately 3,000 droplet nuclei. One sneeze can release tens of thousands of droplet nuclei. And the transmission occurs when another person inhales these droplets. So what happens when there are droplets produced? There are larger droplets as well as smaller droplets. So larger droplets settle to the ground quickly, and there they can be dried. But the smaller droplets become droplet nuclei of approximately 1 to 5 micrometer in diameter, and they remain airborne. And these are the problematic. So on the right side there is an infected person. Whenever he sneezes, the droplet nuclei comes out and they can go to a healthy person. Probability that the TB will be transmitted depends on infectiousness of person with tuberculosis disease, environment in which exposure occurred, the length of exposure, and the virulence of the tubercle bacilli. See, for transmission point of view, all respiratory diseases are same, whether it is COVID or it is tuberculosis. They all transmit in the very same way. So if a person is having more load of bacilli, for the first point, infectiousness of the person, if he is having more load of the bacilli, the chances are that the more bacilli will be releasing in the every droplet. Environment in which exposure occurred. Suppose if you are sitting in this room for 6 hours, what is happening? Every one of you is breathing and they are releasing the droplets into the environment. If this room is not ventilated, after some time we all will be inhaling in the air which is full of droplets or the droplet nuclei. So for prevention of any respiratory illness, if you cannot do any other thing, just choose a proper ventilation, right? Whether it is tuberculosis or it is COVID. So if it is COVID, remove all the air conditioners, open and door your windows, and let the air ventilate it. If the virus is not accumulating in the air inside the room, the probability of you getting it will be very less. Okay? Length of exposure, if you are sitting in a room which is not ventilated for a longer duration, your chances will be increasing exponentially. The best way to stop transmission is to, one thing, you can isolate the infectious person, and then you can provide effective treatment to the infectious person as soon as possible. TB germs cannot be spread by sharing dishes and utensils, using towels and linens, handling food, sharing cell phones, and the touching computer keyboards. So spread of the TB to the other parts of the body, basically it's a respiratory disease. So lungs will see the 85% of the all cases. Then it can involve pleura, central nervous system, lymph nodes, genitourinary system, bones and joints, and it can lead to the disseminated, means involving many organs in the body. Pathogenesis. How does it cause the infection? It occurs when tuberculous bacilli are in the body, but the immune system is keeping them under control. That is for latent TB infection. It is detected by the Mantox. As I said, you may be infected and may not be manifesting the disease. So this is the same situation, latent TB infection. So bacilli is in the body, but still it has not shown any kind of disease. So how are you going to detect it? We detect it with the help of a Mantox tuberculin skin test, or by the blood test such as interferon gamma release assay, IGRA. So IGRA could be of like quantiferon TB gold test, quantiferon TB gold in tube test, or the T-spot TB test. It is to be remembered that the people with LTBI are not infectious. When TB infection becomes TB disease, it develops when the immune system cannot keep tubercle bacilli under control. It may develop very soon after infection, or may develop many years after the infection. It all depends upon the person's immunity. So about 10% of all people with a normal immune system who have LTBI will develop tuberculosis disease at some point in their lives. People with TB disease are often infectious. The essential pathology in a tuberculosis is a characteristic lesion which is called as tubercle. It's an avascular granuloma where the central zone consists of giant cells and there is a peripheral zones of lymphocytes and fibroblast. So this is the diagram of a granuloma. In the center you can see epithelioid cells which are containing mycobacteria inside them. At the very center there is a multinuclear giant cells. Ultimately, a fibrin layer develops around this granuloma, which walls of the lesion. The typical progression in pulmonary tuberculosis involves caseation, calcification, and later on cavity formation. So, droplet nuclei containing tubercle bacilli are inhaled, enter the lungs, and they travel to the last small air sacs, that is alveoli. So they multiply in the alveoli, and this is the site where the infection begins. And some small number of the tubercle bacilli may enter the bloodstream and then they spread through the entire body. In the LTBI, special immune cells form a barrier shell. So in the alveoli they have contained the bacilli. So within 2 to 8 weeks, the immune system produces special immune cells called macrophages that surround the tubercle bacilli, and these cells form a barrier shell that keeps the bacilli contained and under control. So till this barrier is maintained, this will be LTBI. When this barrier is lowered, then it will manifest as disease. This is Ghon's focus. What is it? So Ghon focus together with enlarged hilar lymph node is called Ghon complex or primary complex. A calcified Ghon complex is called Ranke's complex. TB disease. As I said, when this barrier or this shell breaks down, tubercle bacilli will escape and multiply in the other part of the bodies as well. So if the immune system cannot keep tubercle bacilli under control, bacilli begin to multiply rapidly and cause TB disease. This process can occur in different places in the body. So typical progression of pulmonary tuberculosis. First of all, there will be pneumonia, then there will be granuloma formation with fibrosis, then there will be caseous necrosis where the tissue becomes dry and amorphous, and there will be a mixture of the protein and fat. Later on there will be calcification, and last will be the cavity formation where the center liquefies and empties into the bronchi. Difference between LTBI and a TB disease. So we'll see only the bold points. Latent tuberculosis infection is inactive while the TB disease is active. in the chest X-ray will be normal in LTBI while it will be abnormal, showing the cavitary patches. Sputum will be negative in case of LTBI while it will be positive in case of tuberculosis disease. Symptoms are usually not present in LTBI while there will be cough, fever and weight loss in the active TB disease. LTBI is not infectious while TB disease is infectious, and latent tuberculosis infection is not a case of TB while tuberculosis disease is a case of tuberculosis. Culture characteristic of tuberculosis bacilli. It's an obligate aerobe. It's a slow growing one where the generation time is approximately 20 hours, and this slow growth rate is due to the sluggish action of the organism's RNA polymerase, which takes more time for the multiplication. So who is going to tell me what is an obligate aerobe? They can survive in the presence of oxygen. They can only survive if oxygen is present. Next. खड़ा हो, तेरा खुसर पुसर बंद नहीं होगा, तू खड़ा ही रहेगा भी पूरी क्लास में. What is obligate anaerobe? नहीं मिली तो मर जाएगा. What is facultative anaerobe? So a facultative anaerobe is by nature aerobe or anaerobe, but it may survive under the good. But still तू खड़ा ही रहे. मुझे भी दिख रहा है. ये जो मास्क है ना, कुछ लोग बड़ा मिसयूज करते हैं, right? And you are one of them. So it can grow on both solid and liquid media. Solid media are your Lowenstein-Janssen media, Dorset eggs media, Tarshis media, Loeffler and Pavlovsky's media. The LJ is most commonly used one, and for the liquid culture we are having Dubose, Middlebrooks, Sulas or the Stoughton's media. On the solid media, colonies takes 3 to 6 weeks to grow. These colonies are usually buff or beige color and have a rough, dry, granular appearance. On the liquid media, they will form a surface follicle. So this is how they appear on the any solid media. Sit down. Biochemical reactions, when you do that, you will find they are niacin positive, they are aryl sulfatase negative. Neutral red test will be shown positive by only virulent mycobacteria. Nitrate test is positive. Catalase test, they are weakly positive, and peroxidase test, they are positive. Laboratory diagnosis of tuberculosis. So evidence of active disease can be deduced from the sputum, which will be AFP positive, or the direct evidence of infection. We can go for the PCR or culture as well, and if you take a biopsy, it can be seen in as a histopathological evidence. Then evidence of infection rather than disease are the chest X-ray. You will see hilar lymphadenopathy or calcification of the primary focus or lymph nodes, and the delayed hypersensitivity response to the purified protein derivative in the Mantox test. Targeted testing is a TB control strategy which is used to identify and treat person which are at higher risk for infection with tuberculosis, at high risk for developing TB disease once infected with tuberculosis. We defined all the high risk groups in the earlier slides. Identifying persons with LTBI is an important goal to TB elimination because LTBI treatment can prevent the development of the further disease, and it may help you to stop the spread of tuberculosis. Basically, this LTBI is the problem due to which we cannot eliminate the tuberculosis very easily, because the person who is carrying the bacilli inside him, but it's not manifesting as a disease. When it becomes evident, it takes some time for you to find the person and treat him, and by that time this patient has given the disease to the further people. So diagnosis of LTBI, available testing methods are Mantox tuberculin test, blood test, as we said, quantiferon and T-spot. So Mantox tuberculin skin test, how it is performed. This is administered by an injection. This tuberculin is made from proteins derived from inactive tubercle bacilli. Most people who have TB infection will have a reaction at injection site. So 0.1 ml of 5 tuberculin units of liquid tuberculin are injected between the layers of skin. and after 48 to 72 hours you will examine it. You will palpate it and you will see if there is any induration is present. Induration will be measured in millimeters. An induration of more than 5 mm is considered positive for those people who are living with HIV, where the immunity is little bit low. So recent close contact of the people with infectious TB, people with chest X-ray findings suggestive of previous tuberculosis disease, people with organ transplants and other immunosuppressed patients. But in induration of 10 mm will be considered positive in people who inject drugs, people who live or work in high-risk congregate settings, or mycobacteriology laboratory workers. Induration of 10 mm is considered a positive reaction for people with certain medical conditions that increase risk for tuberculosis, children younger than 4 years old, infants, children or adolescents exposed to adults in high-risk categories, and induration of 15 mm will be considered positive for people who have no known risk factor for tuberculosis. Certain people can have a false positive reaction in tuberculin test, like infection with non-tuberculous mycobacteria, BCG vaccination, administration of the incorrect antigen, and the incorrect measuring or interpretation of the test reaction. People who have been vaccinated in the past with BCG may have a false positive TST reaction. Individuals should always be further evaluated if they have a positive TST reaction. But as it can be false positive, it can be false negative also. So energy means where the body is not able to mount any immune response. Recent TB infection means within the past 8 to 10 weeks only. Younger children were less than 6 months of age where the immune system has not developed. The recent live virus vaccination, incorrect method of giving the injection, and there is an incorrect measuring or interpretation of reaction. Any patient with symptoms of TB disease should be evaluated for TB disease regardless of his or her skin test reaction. If a person is having active symptoms like cough, fever, and the weight loss history, whatever his result, you will evaluate it further. In the medical history, clinicians should ask patient if they have symptoms of TB disease, have they been exposed to a person with infectious TB or have risk factors, is there any risk factors for developing TB disease, or if he had any Ltbi or TB disease before. The symptoms which we look for are fever, chills, night sweats, weight loss, appetite loss, fatigue and malaise. Cough will be usually lasting more than 2 weeks. There might be chest pain, or person may be coughing up sputum with blood. Symptoms of extrapulmonary tuberculosis depend on which body part is involved. For example, TB spine may cause back pain, and the TB disease in kidney may cause blood in urine, hematuria. When a person has TB disease in lungs, the chest X-ray usually appears abnormal. It may show infiltrate, which is the collection of fluid and cells in lung tissue, and cavities, which are hollow spaces within lung. A chest X-ray can help you rule out possibility of pulmonary TB disease in person who have a positive TST or IGRA, and you can check for other lung abnormalities also. Bacteriological examination from the point of view of microbiology, this is the most important one. So it has 5 parts. One thing is specimen collection, examination of AFB smears, direct identification of the specimen, specimen culturing and identification, and drug susceptibility testing. These are the sample which can be collected, like sputum, induced sputum, bronchoscopy or gastric washing, sputum in an adult, induced sputum where a person is having symptom but is not able to produce the cough, bronchoscopy when you are trying to detect it in the lower respiratory, and the gastric washing in the case of younger children who cannot expectorate. So easiest and the least expensive method is to have patient cough into the sterile container. The healthcare worker should instruct the patient. They should provide at least 2 specimens at 8 to 24 hour interval, and at least one of them should be the early morning sample. So basic concept is when the person visits and you are suspecting him, You will ask him to submit at least one sample today, and you will ask him to come tomorrow with a sample taken at the home, early morning sample. We think that the tubercle bacilli are collected in the lungs overnight, and when you expectorate first in the morning, there will be more concentration. Induced sputum collection should be used if a patient cannot cough up sputum or their own. So here patient inhales saline mist, which causes the retching reflex, and so deep coughing can be induced. Specimen is often clear and watery and should be labeled as induced specimen. Bronchoscopy may be used if a patient cannot cough up enough sputum. If an induced sputum cannot be obtained, the procedure will be to instrument is passed through nose or mouth into lungs to obtain pulmonary secretions or the lung tissue. And gastric washing is usually only used if sample cannot be obtained from other procedure, often used with children. A tube is inserted through nose and into stomach to obtain gastric secretions that may contain sputum. Specimen other than for extrapulmonary tuberculosis, depending upon which body part is affected. So if you are looking for the TB of the kidney, you will ask the patient to provide urine samples, three samples on 3 consecutive days, and that too early morning. The same concept, probably the bacilli, the concentration of the bacilli increases in the urinary bladder over the night. And the fluid samples from area surrounding spine for TB meningitis. Specimens are then smeared and stained. The Ziehl-Neelsen stain is used most commonly to demonstrate the presence of the bacilli in a smear. The technique is simple and inexpensive. So this is how they look, a blue background and the red colored beaded bacilli. Once you have found that the bacilli are present, the number of AFB on the smear are counted. The smear is graded as per RNTCP grading. These things are often asked in your exam. Practical. Stand up. White one. You know. Get out. Leave the class. And you will meet me in the department tomorrow. Take your phone. If the smear is positive, you are supposed to grade it, because the grading is having diagnostic as well as prognostic importance. So this is how you grade it. If you are seeing more than 10 acid-fast bacilli per oil immersion field, is there anything funny on the last bench? Both of you. Stand up. See, I can give one complete hour to discipline you people, because I know majority is not interested in listening. हाँ, वो बाहर गया तो खुशी हो रही है दिल को, जाना है साथ में, चले जाओ, अच्छा लगेगा उसको भी, कोई तो साथ आया. नंबर बोलो दोनों अपने. You also come and meet me in the department tomorrow. Roll number 138. नाम लाउडली और जोर से. मास्क हटा दे. अभी बोल. विश्वास. नेक्स्ट 93. देखो तो पहले भी वार्निंग मिल चुकी है ना मेरे से, नहीं मिली अभी तक, आज पहली बार है. चलो एक ही बार काफ़ी है. नाम बोलो. राहुल. तो तीनों आ जाना कल, क्लास छोड़ो, निकलो. उसको भी ले जाना, बगल वाले को. नहीं ठीक, जाना है तो तू भी चला जा. तू भी काफ़ी देर से हंस रहा है, मेरे को दिख रहा है. चलो खड़े हो. So if there is a more than 10 acid-fast bacilli per oil immersion field, you will call it positive. The grade will be 3+, and the minimum field which you will examine will be 20. If you see 1 to 10 bacilli per oil immersion field, the grade is 2+, and the minimum fields which are supposed to be examined are 50. If you find 11 to 99 bacilli in 100 oil immersion field, that is 1+, and you will minimum examine 100 fields. If you find 1 to 9 acid-fast bacilli in 100 oil immersion field, first and scanty में 100 लिखना रह गया है, so then it will be called scanty. And if you do not find even a single bacilli in 100 fields, that is called negative. So what are the advantages of the Zeal-Nielsen staining? It's a rapid method, highly specific. If AFB is present in sputum, that means it is having TB disease. So all Mycobacterium are acid fast. There is no exception for it. More than 98% for AFB it's positive for more than 98% in high burden countries. It gives accurate diagnosis, but there are certain disadvantages. It's having a low sensitivity. The reported sensitivity ranging 25 to 65% when compared to the culture, and species differentiation is impossible because by just seeing the bacilli, you cannot say from which species it belongs to. It could be MTV, it could be non-tuberculous mycobacteria. Smear positive patients are 4 to 20 times more infectious. If untreated, a smear positive patient may infect 10 to 15 persons per year. Sputum positive patients are much more likely to die if untreated. For the direct microscopy, you can use fluorescent dye method also, where you will use Auramine O and the Rhodamine B. It is good for labs with high workload. Auramine O is bright yellow in color, and Auramine O Rhodamine B gives you yellow-orange color. And this is how they appear against a green background. You will see yellow-colored bacilli. You will culture them on the LJ medium. So it determines if the specimen contains Mycobacterium tuberculosis, and it confirms the diagnosis of TB. So all specimens which are positive should be cultured. So we will detect the growth of the Mycobacteria on solid media in 3 to 6 weeks, and on liquid media from 4 to 14 days. So they grow faster in the liquid media. Identify organism that has grown. We can do it by the help of the nucleic acid probes in 2 to 4 hours, and with the help of biochemical test in 6 to 12 weeks. So if I combine the usage of liquid media with the help of nucleic acid probes, we can reduce the number of days which takes for the diagnosis of tuberculosis. And then we perform the drug susceptibility testing, means whether the organism is susceptible to the first line or the second line of the drug or not. These are the 3 methods by which we do it: absolute concentration method, resistance ratio method, and proportion method. The test should be repeated if the patient is positive after 3 months of the treatment and the patient does not get better symptomatically. This is Midget is a liquid system based method. PCR, nowadays you can definitely send a PCR. Prevention, how can we prevent it? So adequate nutrition, good housing, health education, and the healthy environment are very necessary. There is a specific vaccine for it, that is Bacilli Guerin. It's a live strain of the Mycobacterium bovis developed by French scientist and Guerin for use as an attenuated vaccine to prevent tuberculosis and other mycobacterial infection. It was first administered to the human in 1921, and it's the only vaccine which is active against tuberculosis. The standard dose of the BCG vaccine is 0.1 milligram in 1 ml administered intradermally. Other childhood vaccines can be administered simultaneously with BCG. The durability of protection is generally believed to be approximately 10 to 15 years. BCG vaccine efficacy appears to be dependent on 3 factors. One thing is the underlying immune status of the recipient, the extent of background exposure to mycobacteria prior to vaccination, and perhaps the potency of the BCG vaccine strain which was used. Actually, nowadays BCG vaccination is not used worldwide. Now, if you remember the early part of the COVID, there was a huge cry about this, because European countries and American countries, BCG is not part of their vaccination program, and it was claimed that because India is having BCG in their universal immunization program, that's why we are having less number of COVID patients, and they were having more number of COVID patients. Later on, this could not be proven, but the point is, all countries, particularly few developed countries, do not impose the BCG vaccination on their residents, while in our country, BCG is the part of the universal immunization program, and it is administered on the day 0 or the day 1 of the to the newborn. These are certain side effects: skin ulceration, regional lymphadenitis, subcutaneous abscess, generalized like anaphylaxis, generalized BCG infection. It can lead to osteitis. Potential factors affecting the rate of adverse reactions include the BCG dose, vaccine strain, and method of vaccine administration. All of you would have seen a scar mark on your left arm. There are certain other BCG vaccine, TB vaccine in pipeline, but none of them have been approved. Treatment, mainly you will read it into the pharmacology, but just to summarize it, there could be of two types: bactericidal and bacteriostatic. Then there are first line drugs and there are second line drugs. And you can find resistance in tubercle bacilli nowadays. So multi-drug resistant and XTR tuberculosis, these are the two terms which are commonly asked. So multi-drug resistant is resistant to at least isoniazid and rifampicin, means it should be resistant to both of them. Okay, and XTR resistant to isoniazid means MDR plus resistant to any fluoroquinolone and at least one of the three injectable second line drugs, which are amikacin, kanamycin or capreomycin. So grading of sputum smear, then treatment, MDR and XTR, these are commonly asked questions in your practicals. Tuberculosis is very oftenly asked long question. They will be giving you a history of a person suffering from fever, cough and weight loss. What are the things you will like to do for that patient?